Great. So my name's Chike. I'm from the research team in Leicester. I work as a consultant there as well. So I'm going to chair this session. And as Karen says, we've got some real true experts in the field. So very lucky to have these speakers. I'm going to start by introducing Professor Barratt. Jonathan is a consultant nephrologist, leads laboratory and clinical research in Leicester, and will give us a talk on IgA nephropathy, a beginner's guide.
So welcome everyone. As Karen says, please feel free to shout out and interrupt at any time if you've got a question. This is purely and simply an event so that you guys get to learn more about the disease. And I know there are people here as well with HSP or IgA vasculitis. And so I'm going to try and touch on how that intertwines with IgA nephropathy in this talk as well. So I want to take you back to 1968. So I'm looking around the room, and I'm not going to say who I think was probably around in 1968. But there was some devastating fashion. Richard Nixon was just elected president of the US. There was the Mexico Olympics. Martin Luther King was assassinated. First manned flight around the moon. Planet of the Apes, 2001. We're on at the cinema. And just across the channel, this gentleman, Jean Berger, first described IgA nephropathy. And he was able to describe it because someone developed a way of looking at kidney biopsies and being able to stain the kidney for IgA in the very fine filters in the kidneys. So IgA this year is celebrating its 50th anniversary. But clearly IgA nephropathy didn't just suddenly appear in 1968. So if we look back, there have been studies performed on people that lived in the 18th century that show that they too had IgA nephropathy. Didn't know it at the time, but because they were important people, their organs were preserved, and people have gone back and looked at them. So I know one person in the room knows who this guy is. Does anyone else? So this is the father of the US Navy, and his claim to fame, I learnt, was that he famously invaded the UK on behalf of America. It didn't work, but when people looked at his kidneys, he was shown to have IgA nephropathy, along with the Crown Prince of here, Joseph Habsburg. So we know it's been around since at least the 18th century. And since its first description 50 years ago, it's now regarded as the commonest pattern of glomerulonephritis in the world. But it is rare in the UK. IgA vasculitis is even rarer. And so one of the things that's come up from these days is patients often sit in clinic with another 30 people going to see the consultant, and there won't be another IgA nephropathy patient in the room. You'll never have met someone with IgA nephropathy or IgA vasculitis before. The likelihood is your GP only probably has one patient with IgA vasculitis out of the 10,000 on their list. So that means that it's often very challenging to get information because you have a rare disease, and I'll come back to that, for the initiatives that are happening in the UK to try and look at these diseases. So let's start with the kidneys. So the kidneys are here, sitting in the small of your back. In IgA nephropathy and IgA vasculitis, both kidneys are affected equally. One of the commonest questions we have is it just the right or the left kidney? Both kidneys are equally affected. So what do the kidneys do? Well, the kidneys control your salt and water balance. So any of you that go to see the nephrologist regularly will know we are obsessed by whether your ankles are swelling. And that's because if your kidneys aren't working, you retain salt and water. And the first place we see that is on your ankles. They're involved in getting rid of all the products that the body doesn't need anymore. And when the kidney function gets very low, these waste products can start causing symptoms. They can start making you feel sick, not wanting to eat, itchy. And that's the sign that these waste products are building up. They also generate hormones, so they're very important in controlling vitamin D. And vitamin D is very important in maintaining the health of your bones. They also produce a drug called EPO. So anyone who follows the Tour de France will realise there's lots of cyclists love taking EPO, allegedly. This has been streamed, isn't it? So I've got to be careful. But this stops you from becoming anemic. So for some of you who may have developed dialysis-dependent renal failure, you may well be given EPO as an injection to try and get your blood count back to normal. And Finally, and perhaps one of the most important things, is the kidneys control your blood pressure. And you'll all have been to see a kidney doctor, and we are obsessed with your blood pressure because kidney disease causes high blood pressure, and high blood pressure damages kidneys. And you get into a vicious cycle, if you're not careful, of one causing the other, making the other worse, which is why we are very, very concerned about people who have high blood pressure. We want to make sure we treat that as well as possible. And so how do the kidneys do this? Well, the kidneys are processing a litre of blood every minute. So they are cleaning a litre of blood every minute. That means 180 litres are filtered a day. You have 5 litres, roughly, circulating blood volume, which means your blood is entirely cleaned at least 60 times a day. Now, clearly, that isn't all produced as urine, so the kidneys actually reabsorb the vast majority of the fluid that they filter, or else you'd turn out like a crisp in about an hour because you've lost all your fluid. So the kidneys are working continually, both of them simultaneously, to clean your blood of any toxins or any excess salt or water that you have in your body. And to do this, the kidneys have a very, very precise filtering mechanism. So each of the kidneys contains 1 million of these structures called nephrons, and that's why we're called nephrologists, because we look after the nephron. And essentially what this comprises is a filter. So essentially a very, very well-defined sieve that sieves the blood, produces the early urine, then all of that urine flows down this tubule, this plumbing network, and most of what's filtered is reabsorbed by the body. And there are 1 million of these in each kidney. And this is one of those filters in a bit of a larger scale. And essentially that filter is a very, very complicated loop of blood vessels that are microscopic, so you need a microscope to see them. But for 2 organs that are essentially the sizes of my fist, if you were to look at the amount of capillaries in those 2 organs, it would stretch out to 19 kilometers. And so just to put that into perspective, what that would do is if we laid out your capillaries in your kidneys, you'd be able to go from here down to the Tower of London, you'd go and visit Downing Street, you'd come back to Nelson's Column, up to Buckingham Palace and back to the Wellcome Trust. If you laid all the capillaries, the blood vessels that are in your 2 kidneys out in one long length. So that's a phenomenal area that is filtering your blood every second of every minute of every day. So hands up who's had a kidney biopsy. So I have done lots of kidney biopsies and it never hurt me once, but I guess that it wasn't necessarily that much of a nice experience for most of you, and you won't have seen what happened because you were lying on your front. So the only way we can diagnose nearly all of the glomerular diseases is with a kidney biopsy, and that's the only way we can diagnose IgA nephropathy. And so this is what we get at the end of it, which again you're unlikely to have seen because you were swearing on your front, thinking that was more painful than the doctor said. So that's a very small core, a little cylinder of kidney tissue. And normally we take 2 or 3 of these to make sure we have enough tissue to make a diagnosis. And then we look at it under the microscope. And what we see, so this is a section through there, is there's the one side and there's the other side. And those very fine filters are these balls. So these little balls of cells here, each of those, there's 1, 2, 3, 4, 5 filters in that screen. And these are the tubules that then do all the reabsorption. So this is what we're looking at under the microscope to make a diagnosis of what type of kidney disease you might have. And in IgA nephropathy, what we see is that each of those fine filters is full of the protein IgA. So this is that core again. So there's one side of the core, there's the other side. And these are the little fine filters, the balls. And they've been stained for IgA. So every little filter, so all million of the filters in both kidneys is full of this IgA protein. And that's what gives you IgA nephropathy. And if you had IgA vasculitis, it would look exactly the same. There is IgA stuck in those fine filters. So what is IgA? Well, IgA is one of your antibodies. So everyone has it. And what it normally does, it's passed into your spit, into the secretions in your bowel, in your urinary system, in your lungs, to protect you against bacteria. And it essentially coats those surfaces and acts as an antimicrobial paint to stop the bugs getting in. We all have IgA in our bloodstream, but we don't quite know what it does, but it's there. And in IgA nephropathy, there's something subtly different about the IgA that patients have compared to people who don't have the kidney disease. So just some terminology which you will have heard many times. An inflammation of the fine filters, these balls of cells here, is called a glomerulonephritis. Okay? An IgA nephropathy is just one type of glomerulonephritis. There are lots of different types, but that's what we're talking about when we say a glomerulonephritis. And so what does this IgA depositing in the kidney do? Well, my guess is most of you will have been told you've got blood in the urine, hematuria. Some of you may well have actually seen blood when you've picked up a cough or a cold or a stomach upset. And often that urine doesn't look red, like you've cut yourself. It looks like Coca-Cola or it looks like tea. It's got that kind of dark brown colour. Most of you, if not all of you, will have blood in the urine that you can't see, so-called microscopic hematuria, and that can only be seen on a dipstick. And often that's there for the rest of your life. It may come and go a little, but often it's there all the time. And one of the challenges we have is when you feel unwell and someone dips your urine and they don't know you've got a kidney disease, they assume you've got a water infection. Because one of the commonest causes of blood in the urine is a water infection. So it's always worth remembering to tell whoever's dipped your urine that you do know you have a kidney disease, so don't automatically assume it's a water infection. And I really like these pictures. So this is why blood gets in the urine. So this is one of those fine capillary loops, and this is a red blood cell, these very dark things here. And what you can see here is a red blood cell getting through, getting through the wall of the blood vessel. So this is rather like me putting my trousers on this morning. You're squeezing in, and you can see here that blood cell is squeezing through the very tiny holes that are in the loops and getting into the urine. And if you've got IgA in the kidney and there's inflammation in these blood vessels, clearly these blood cells are going to be able to get into the urine more easily. And that's why we see blood in the urine. The other thing that we look for and that you may well have is protein in the urine, proteinuria. And again, that's normally identified by a dipstick test. If you have lots and lots of protein in the urine, you can often look when you've had a pee that you've got a real foamy top in the toilet, like a head of beer. And that's associated with lots and lots of protein in the urine. And so often people may well notice that with certain other forms of kidney disease, but that's something that we do see. The other thing is you may well have been shown to have high blood pressure. So some people with IgA nephropathy, it all comes from the fact that for some reason someone's had their blood pressure measured and it's high. And that triggers a series of tests that ultimately lead to you being identified as having IgA nephropathy. And finally, you may have had the joy of a blood test where we check your kidney function, because that's really the only way to know how well your kidneys are working is with a blood test. And we measure the creatinine level in the blood, and then we use that to calculate a number called GFR, which in all intents and purposes we can say is a percentage of your kidney function. So if you have a GFR of 100, that's normal, that's 100%. If you have a GFR of 30, that means your kidneys, both of them, are collectively working at about 30% of what we would expect them to be. But none of these symptoms tell me that you have IgA nephropathy, because they can happen with all sorts of different kidney diseases, and that's why we need the kidney biopsy, which is why all of you had the delight of a kidney biopsy to get the diagnosis. So I guess when Phil runs the patient groups this afternoon, we're going to hear how variable this disease is and how it's affected everyone very differently. And IgA nephropathy is truly a very, very variable disease. And I just want to show you some things. So this is the proportion of kidney biopsies that are diagnosed with IgA nephropathy. So in the West, so we have around 1 in 4 of the kidney biopsies that we do in Leicester has IgA nephropathy on it. If we go out to Southeast Asia, half of them at least are IgA nephropathy. So IgA nephropathy gets much, much more common as you move from the west to the east. And we don't know why. In fact, it's so common in Asia that even the dogs get IgA nephropathy. We don't know why in the UK and other Caucasian countries, 3 times as many men are likely to get IgA nephropathy as ladies. But if we move over to Asia, it's 1-to-1. In fact, some places, women are more likely to get IgA. We just don't understand that. And perhaps the most important thing that we are working on hard in Leicester to try and understand is why everyone in this room will have kidney biopsies that show IgA in the kidney, yet some of you will live your life with normal kidney function. And others, over a period of time, will develop progressive kidney damage and end up needing dialysis or a kidney transplant, despite everyone's biopsy showing the same IgA stuck in the kidney. And that's something that we are working really hard to try and understand so that we can tease out what's different between patients. So what happens with IgA nephropathy? Well, it can go away completely. It doesn't happen very often. More often happens in kids. More likely, you're going to have it for the rest of your life. And in some people, it will cause no issue, no inflammation and scarring to the kidneys, but in others, there will be a slow loss of kidney function as there is gradual inflammation and scarring of the very fine filters. And some, about 20%, 30% of people with IgA will develop significant kidney scarring, meaning that the kidneys stop altogether, in which case you'll need dialysis or a kidney transplant. And for those who have a kidney transplant, there is a potential that the disease will come back in the kidney transplant. And that's because the disease is a disease of the IgA that's circulating in your blood. So if you plumb a new kidney in, that new kidney is exposed to the same IgA that your old kidneys are exposed to. But nearly always in IgA nephropathy, things happen slowly. They happen over years, 10 years, 15 years. Some people, unfortunately, it's very quickly, but in the vast majority, it's a very slow progression, so there's time to think and talk about it. So can we predict what's happening, what will happen? So if you just have blood in the urine, either you see it yourself or it's on a dipstick, you're likely to do very well. The likelihood of you developing progressive kidney scarring is very, very small, unless you live in Asia, in which case there is a risk that even with that very minor changes, you will end up with kidney scarring, again suggesting the disease is very different. The things that get us worried as nephrologists and make us think that kidney scarring may happen is if you've got more protein in the urine, your blood pressure is high, or your kidney blood tests are abnormal. Yeah?
My question with this is, right, what I don't understand is, my understanding of the SID mechanism in the glomerulus is that you know, they're like little holes, and the red blood cells of the protein passes through these little holes into the tubules. But I always understood that protein molecules, you know, albumin, was much smaller than red blood cells.
So it is.
So I don't understand.
Yeah.
Well, I don't understand why you know, if somebody's got blood in the urine, they haven't got really high levels of protein in the urine as well, because red blood cells are bigger than protein.
So you're absolutely right. Red blood cells are much, much bigger than protein molecules. The difference is that the reason protein is more damaging is because the red blood cells going through the kidneys are benign. They don't cause any mischief as they go through the kidneys and come out in the urine. What we know for sure is if you have protein that leaks across the fine filter, it damages the rest of the kidney as it goes down. So the albumin, the protein that's leaking, is interacting with the cells in the rest of the nephron, causing damage as it goes down, whereas the red blood cells just pass through and don't cause any problems at all. So that's why, because we know that even though the protein is a marker of damage to the fine filters, it's also causing damage as it goes down, which is why we really want to reduce the amount of protein that appears in the urine. Because we're not just affecting what happens in the filters, we're affecting what happens in the rest of the kidney as well.
With that point regarding protein, does that mean a low protein diet is ideal for IgA sufferers?
No.
Okay, explain.
So the protein that's getting through is your normal protein that's present. We don't want to reduce the protein in your bloodstream because that's doing lots of important things. There has been lots of interest in low protein diets for people who have have severe kidney disease, and it was thought to be a way of slowing down the progression of all forms of kidney disease. But that data has not held up over time. And so the most important thing in terms of diet, if you have IgA nephropathy, is to have a balanced, healthy diet. Your 5 a day, in line with everyone else in the country. There's no evidence that any particular diet improves your outcome if you have IgA nephropathy or IgA vasculitis. The other thing that we use is we look at your kidney biopsy, and we look at the extent of inflammation and scarring on your kidney biopsy, not just within the filters, but also within the rest of the kidney. And you may or may not have heard of this thing called the Oxford classification, which was developed, unsurprisingly, in Oxford by a team of pathologists and kidney doctors from around the world. So all of the kidney biopsies are now scored using this system. And the importance of this is that next year, we are going to release an app that will allow people to predict the likelihood of them developing progressive kidney scarring using the data from their kidney biopsy and their proteinuria, whether they have high blood pressure, and their level of kidney function. And this is work that the international IgA nephropathy community have done, led by a guy called Sean Barber in Vancouver. And he has data from over 5,000 patients from Japan, China, and the UK. He's put all that information in. He's known what's happened to them over the 5 years from their biopsy. And he's generated a very complicated equation that allows you to use this information to put into an app that is then going to give you a risk of your likelihood of your kidney function getting worse over the next 2, 3, 4, 5 years. So we're just waiting for that scientific paper to be published, and then the app will become available, and it'll be able to be downloaded from the App Store. So I will feed out to everyone when that is out there. It really, at the moment, only applies at the time you have a kidney biopsy, but we're working through the data, or Sean is, to make it relevant if it's a year since you had your biopsy, 2 years since you had your biopsy. So we're making real ground here in being able to give individual patients at the time that they're given the diagnosis a clear idea about what might happen in the future. Yeah?
How about patients that had biopsy done 10 years ago, like in my case? Would you recommend that they have biopsy taken again?
So for me, the most important predictor of the future is what's happened in the past. So what I would do with a patient who has a long history of IgA is I plot out what's happened to your kidney function over time, and I can produce a graph. And normally, kidney function gets worse at a relatively predictable way. And that means that I can predict how much kidney function is being lost per year, and I can predict then when you're likely to hit a level where we need to start thinking about kidney transplants and dialysis.
Okay.
And so most kidney units will have, and in fact on patient view, which I guess a lot of you will have, you can graphically represent your kidney function. And that's essentially what we do in clinic, is we look at the kidney function, and what we're trying to do is slow that rate of loss. But if you've got 10 years worth of data about what's happened to your kidney function, that will help me predict what's going to happen in the future.
All right. Thank you.
So I've covered that. So what's the cause? Now I could spend the whole day talking about the pathogenesis of this disease, because that's what I do, but I've been told by Karen a limited number of slides. So the bottom line is we don't know. But there are lots of people around the world working really hard to try and find out what the cause of this disease is in IgA vasculitis. We know there's something about the IgA in patients with IgA nephropathy that's subtly different to people who don't have the disease. And this is something that we've done. So this is a single IgA molecule. So we are working down to the level of individual IgA molecules to work out if we can compare the shape of an IgA molecule from someone who doesn't have IgA nephropathy to an IgA molecule for someone who does. And this is, in fact, Phil, who's just sat there. That's his IgA. So that because Phil has given us I don't know how many litres of blood over the years to help with our research. So, and so this is the level at which we're working at, to the level of single molecules to try and work out what is different. We also know that there are subtle differences in the way the immune system generates the IgA. And most obviously, I don't know if anyone in the room has had this, a cough or a cold, and within 48 hours you're peeing blood. And that tells us that it's something about the immune system within your respiratory tract or your gut that is abnormal, that is generating this IgA that's depositing in the kidneys. And so there's a lot of work looking at this is the lining of the gut here, to think about what's going on in the gut. Could the kidney disease actually be a red herring? And we're talking about a disease that's primarily involved in the bowel or the lungs, generating the IgA that's causing the problem. And there's a lot of interest in the bacteria that live in the gut. Is that driving this immune system to generate the IgA that then gets stuck in the kidneys? So Chike is just about to start a study where we're going to give a specific probiotic, and we're going to see whether tinkering with the bacteria in the gut alters the type of IgA we see in the bloodstream, to see whether that might be related.
So, is it the small intestine or the large intestine?
Oh, sorry.
Would it be the large bowel or the small bowel?
So all parts of the bowel have the bit of the immune system. The most intense area of the immune system is in the end of the small intestine called the ileum,
Okay.
which is where this is in fact based, which is where all these very, very dense immune cells sit. And there's a new drug that's been tested that was specifically designed to target these immune cells in the gut. And that initial result suggested that this might be a way of treating the disease. So treating the kidney disease by targeting the gut. So what's the right treatment? So the most important thing you should walk away for is we are obsessed with your blood pressure. We need to control your blood pressure because we know whatever the cause of kidney disease, if we control your blood pressure, we can slow the rate it gets worse. And you can control your blood pressure with exercise by being the ideal weight, taking tablets, and salt restriction. So when we did the patient day in Manchester, one of the dietitians gave a really nice talk on salt restriction. And in fact, her video is on the Facebook page. So if you go searching for it, she gives some really sensible, easy advice about things you can do to try and reduce your salt. Because even if you do this, and you take tablets, salt restriction will improve yet again your blood pressure control. We want to reduce the protein in your urine exactly for the reason we discussed, because as protein leaks into the kidneys, it damages the kidneys as it goes down into the urine. Getting your blood pressure down will reduce the amount of protein in your urine. There are particular tablets which I would imagine most of you in the room know about, because you're on them.
There's a question on Facebook.
Okay.
And it's somebody's questioning whether ACE and ARB inhibitors are used to treat proteinuria still.
They are. So ACE inhibitors and angiotensin receptor blockers were designed to treat high blood pressure. So we can use them to treat high blood pressure no matter whether you have proteinuria. However, we know that if we treat high blood pressure with another drug, we can get a target blood pressure. If we treat that same patient with one of these drugs and get the same blood pressure, we will get even more protein reduction because of something specific to the way these drugs act. So if you have high blood pressure and you've got protein in the urine, these are the drugs we would want to try first. If you have normal blood pressure and you've got protein in the urine, I will be putting you on one of these as well, because I want to use this to reduce the proteinuria even if you have normal blood pressure. Now clearly the problem there is these tablets are designed to lower your blood pressure and you have normal blood pressure. So the obvious side effect is going to be if I give you too much, your blood pressure is going to come down and you're going to fall over when you stand up, or you're going to feel dizzy. So what we do in that situation is we slowly increase the dose of these drugs to the maximum dose you can tolerate. And that is determined by how well you feel and what your blood pressure does. But even if you've got completely normal blood pressure, we would want you on this to try and reduce the protein.
So I've been on Ramipril for, I don't know, 11 years or something like that. And would that be just basically a normal course of actions taken by a doctor, just give you a Ramipril, or should they also try different one and just measure which one works better in order to reduce proteinuria?
So there's no evidence that any of these are better than any other. So it doesn't matter which one.
Okay.
There was a vogue in the past to use both together, but there have been studies that have come out to suggest that that might not be the right thing to do and might cause other problems. And so the way the international guidelines and what we would recommend is that we would like to have, if you can tolerate, you on either one of these or one of these to the maximum dose that you can take to try and reduce the amount of protein in the urine. If that's not enough to control your blood pressure, we will add additional drugs on, but this is the first one that we would want to use for your blood pressure.
Okay. Thank you.
So is there any specific treatment for IgA nephropathy? So at the moment, unfortunately there isn't. And 5 years ago, we would have thought that actually there was nothing on the horizon. But things have changed dramatically. And now there are 5 or 6 brand new therapies being tested in clinical trials for the treatment of IgA nephropathy. And we hope to move those into IgA vasculitis. So the outlook is absolutely fantastic and completely different to how it was 5 years ago. Some of you may well have been tried on steroids or mycophenolate. If I were to put 100 nephrologists in the room and ask them, would you give steroids or mycophenolate for IgA nephropathy, you would get lots of different answers. And that's because we don't know what the right answer is. So some of you will have had that, some of you won't. And that's simply because we just don't know. The good news is we are doing clinical trials to answer the questions. The only way we know whether a drug truly works and is safe is to do a clinical trial, where we compare the drug against not giving the drug or a placebo. And then we can truly see whether the drug is effective at preventing the kidney scarring and whether it's safe. In your packs is something that I've put out on the Facebook site, but also summarises the clinical research studies that we're doing and tells you the clinical trials that are recruiting at the moment in IgA nephropathy in the UK and the cities, the hospitals that are open for those studies. So you can have a look at those and see whether there's a place near you that might interest you. And come and speak to me at the break if you want to talk about it. I just want to finish off by what's going forward in terms of research, because in the UK we are probably one of the leading countries in IgA nephropathy research. And we're very, very fortunate to have this thing called RaDaR, which is a rare disease registry. And IgA nephropathy and IgA vasculitis are part of RaDaR. And RaDaR is funded in part by Kidney Research UK. And essentially it's a rare disease registry. So at the moment we have over 3,000 patients in the UK with IgA nephropathy in RaDaR. And what that means is because we have a single NHS, and we're the only country in the world to have a single healthcare system, if you're in RaDaR, every time you have a blood test anywhere, that blood test results will automatically go into RaDaR. So what that allows me and other researchers to do is to see what happens to people with this condition over time, to see what happens if you have a kidney transplant, what happens to your kidney function. We can ask a question, do men progress and get kidney failure quicker than women? Do people of different races? Does it matter where you live in the country? We can ask so many different questions because we have the data for a large number of people. And linked with that now, I've been able to get IgA nephropathy and IgA vasculitis onto the NIHR bioresource. Now, this is a centrally funded initiative that allows us to recruit patients, we collect their blood, and we look at their DNA, and we are able to link their DNA to their clinical outcome in RaDaR. And what that means is what I'm aspiring to is to have every patient with IgA nephropathy and IgA vasculitis in RaDaR, and ideally everyone in the bioresource, because that means we will have the DNA, the genetic information about patients linked to what happens to them real-time clinically. And we will be able to look to see whether there are any particular genetic reasons why some people progress faster than others, genetic reasons why some people get the disease back in their kidney transplant rather than others. And also with the bioresource allows us to contact you and say, we've got a new research study, could we ask you to come up and be involved? You don't need to come to Leicester, you come to whichever hospital is closest to you that's part of the bioresource, and you can take part in a study, and we can do that within a month. We can say, we need 500 patients with IgA nephropathy because we need a blood sample, because there's something really important we want to study. And this allows us to be able to test that out, and if you want to be if you're interested, you can come and be part of that. And so these are two fantastic UK-specific initiatives that no other country has. and every other country is very, very jealous of. But of course, that doesn't answer the question, why is the disease so different in different parts of the world? So what I've done is we now have an international version of RADAR, this rare disease registry. And I've worked with Adrian, who's got his eyes shut here, from Singapore, and we've developed the Southeast Asian glomerulonephritis group, which is going to bring international RADAR to the Philippines, to Malaysia, Singapore, Thailand, Indonesia. Dina is one of our PhD students, is going to be bringing that into Indonesia. Sasina, who works with us, is going to be bringing this from Vellore in India. And we also have a contact in Hyderabad in India as well, who's going to start collecting data. And we have a sister renal centre in Nantong in China, and they're going to be collecting data. So suddenly you can start thinking, well, wait a minute, this disease is very different in different parts of the world. Let's compare big populations to see what's different. And there we might be able to understand more about the disease. And so I think the future is looking fantastically optimistic in this condition, both because we have new drugs we're testing, we're getting new information, we've got a fantastic collaborative network across the globe with people interested in working together. But it wouldn't be possible without you guys. And the only way we can do our research is with your support, by you being prepared like Phil to give half his blood volume and keep coming back for more. So we really are appreciative of your involvement in days like this, but also being involved in the research that we do, being prepared to give us a little bit of blood or urine whenever we ask. So I'm going to finish there. And just to convince you that we do have some fun as well as work hard, this is the team in Buenos Aires. So there was a 50th anniversary conference of IgA nephropathy where experts from around the world came and discussed. And I put a summary of that, or Karen generated a summary, which is on the UK Facebook page, of what was discussed. And this is the team. Some of them are here today. And I just want to finish by thanking the mayors who have been incredibly generous in supporting our work in Leicester to the tune of a number of £1 million to help purely help us to research IgA nephropathy, along with other donors who are sat in the room who I'm not going to single out because I want to embarrass them. But I just want to thank you. As I say, please come and catch us at any time to ask questions, and I'm happy to answer any questions now.
Hello, I'd just like to raise a few questions from our online participants that have come in over your talk. So the first question is a combination of ACE and ARB harmful?
So there have been large studies in older people where a combination of ACE and ARB has been shown to increase the risk of cardiovascular events, so events involving the heart and the circulation to the brain. And so the general guidance now is that we don't use them in combination.
Okay, thank you very much. And our second question is from a participant who is on dialysis now and also on a transplant list. And he's asked, am I right in thinking that IgA has had its wicked way with me and cannot dab into my kidneys anymore?
Absolutely. So once you're on dialysis, the kidneys essentially just sit there, they're scarred, and over time they will stop producing any urine and they just won't cause you any trouble. The issue comes if you have a kidney transplant, is that because the IgA is still circulating around your body, there is a risk that it could deposit back in the new kidney and potentially cause inflammation and scarring. Although the data from the large kidney transplant registries is that if you have IgA nephropathy, you do as well, if not better, than anyone else who has a kidney transplant for any other cause of kidney disease. So it's no reason not to want to have a kidney transplant.
Okay, brilliant. And we've just got a third question. So we've got someone who had a transplant 8 years ago, and they've recently had a biopsy that's shown that the IgA is returning. Do you have any advice for them?
So one of the things to say is that IgA can deposit in those filters. Doesn't necessarily mean it's causing any inflammation, it just means it's deposited there. The key thing, as with the normal disease in your normal kidneys, is to make sure your blood pressure is controlled, make sure you're on the ramipril or a drug like that, or losartan, and speak to your transplant consultant about what they're doing with the immunosuppression. But there is no evidence that any particular immunosuppression, if you've got a kidney transplant, is better or worse if you have IgA nephropathy.
Brilliant, thank you very much.
So that was my question. So what is the immunosuppressant still a viable option then, you know, what you said about it, the IgA depositing in the immune system, immunosuppressant still a viable option?
So we definitely need to target the immune system, but we need to be very clever about how we target it, because the immune system's there for a reason, and the major reason is to stop us dying from infections. One of the recent studies looking at the use of steroids in China had to be stopped because the steroids that were being given to patients with IgA nephropathy were causing too many infections. So steroids are very good at damping down inflammation, they're very good at suppressing the immune system, but they come with a number of side effects. And what we're always doing as doctors, when we discuss with you as patients, is balancing the risks and the benefits of the treatments. And at the moment, it's unclear whether the benefits outweigh the risks or the risks outweigh the benefits for steroids in IgA nephropathy. A number of the new treatments that we're using are very much more targeted therapies to target different aspects of the immune system. And the good thing there is they target the immune system so they don't have as many side effects. But because the new therapies are targeting different bits of the immune system, we could use them together. So if one has an effect but not completely removes the disease, we can add in another one because it's doing something very different. So that's why I think it's very exciting going forward, is that we've got a range of new treatments targeting different bits of the immune system that potentially we could use at the beginning and then the middle, and we could use together. But you're right, we need to be targeting the immune system to switch off this IgA that's then depositing in the filters.
You mentioned, and I can never say the word properly, neopathy. See, I told you I couldn't say it. IgA neopathy.
Yeah, nephropathy.
Thank you. And vascular. You didn't explain the difference there.
So,
can someone go from one to the other?
So IgA vasculitis, if you look down a kidney biopsy, they would look identical. But if you have IgA vasculitis, you have disease that affects you outside of the kidney. And so that is often represented by a skin rash, by aches and pains in the joints. It can also lead to inflammation in the lining of the bowel. So that's a very common disease in children. Well, it's the commonest form of inflammation of the blood vessels in children. It's less common in adults. But in terms of the kidney disease, it's very similar to what we see in IgA nephropathy. But for some reason, they have a disease that also affects bits of the body outside of the kidneys. And so one of the things that we're interested in is working out what's different about the two diseases. Because the kidney disease looks identical. But for people with IgA vasculitis, they have this additional issue, which is that there's inflammation in blood vessels outside of the kidneys. So it's an interesting relationship. So there are people who've had identical twins. One's had IgA nephropathy and the other one's had IgA vasculitis. You have people that are told they've got IgA nephropathy, but actually on the Facebook group, we had a bit of a conversation. And actually, in hindsight, some of these people actually remembered having a rash that was very typical of it some time ago, but then it disappeared. And then they came and presented to the doctor, and they had the biopsy, forgot to say about the rash, or said about the rash, and it wasn't noted, and they've been labelled as having IgA nephropathy. So it is very mixed. The rash can occur before you have the kidney disease, it can occur after you have the kidney disease, or it can occur at the same time. And only by talking to someone and taking a really detailed history do you work out whether they actually have a rash that's related to this or not. So it can be quite muddled in terms of getting the diagnosis absolutely right. And we don't have a test to distinguish one from the other.
Could you just explain the term scarring? Is it the same as inflammation?
So what happens normally is the process is the IgA gets deposited, And often there's this inflammation. So rather like if you have an inflammation in the skin and it's very inflamed, red, there's lots of blood flowing there, you get that happening inside in the very fine filters. So you get lots of inflammation there, which we can see down the microscope. You wouldn't notice it necessarily. But if that inflammation doesn't resolve normally, it resolves by scarring. And scar is just dead tissue. It doesn't do anything. So that ball of cells that was doing all that work suddenly gets replaced by a scar that does nothing. So what you have is you have this appearance of inflammation, which in some people settles down and the structure of the filter remains the same. And in others, it goes to the point where it just carries on to the point that there's just scar tissue. And essentially what you look at, if I were to put up a picture of a kidney with scar tissue, those round balls would have no cells in it. It would just be a pink blob, which is just the scar tissue, just like if you cut yourself and you had a scar. It's just essentially concrete that's replaced this functioning tissue. No, unfortunately, so that's the holy grail. So can we stop the inflammation progressing to scarring is what we want to achieve, or can we stop the inflammation in the first place? But once the scar tissue's there, it's there for good, and we can't do anything about that. Okay.
Can we just take one last question and then...
Are we overrunning? Okay.
Thank you. I had a question about treatment, if that's okay. I had a biopsy about a year ago, and I was put on ramipril. My blood pressure was normal, but I had a lot of adverse effects from the drug, mainly dreadful memory loss, not being able to even complete a sentence. I spoke to my nephrologist and he transferred me to Candesartan. Some of the symptoms have gone, but I still have issues with memory. Is that an effect of the drug or is that an effect of the disease?
So it's certainly not an effect of the disease, because IgA nephropathy is very much a kidney disease with nothing else happening outside. In terms of the fact that this thing starts and stops when you take your tablets, it strikes me it's much more likely to be related to the medication. And whether that's related to affecting the blood circulation going to the brain or whether it's something different, I just don't know. What we try and do, so clearly when we give treatments, we don't want to make patients feel worse than they were before they had, because we've not done a very good job. So we always have to balance the benefit of you taking the drug against how that makes you feel. And we have to get a fine balance that you're happy with and that we think is trying to do as much protection to the kidney as possible.
Okay, thanks very much. Thank you very much, John.